Hello, I'm Boon Seng. Today I'll be talking about the approach to hypotension. This is a lecture catered for undergraduate medical students in their internal medicine rotations. We have three learning outcomes. Number one is to describe a logical and practical approach to assessing patients with hypotension, list the differential diagnosis of the patients with hypotension, and I will look at three case reports to describe the overview of management of hypertension, specifically with regards to hypovolemic shock, postural hypertension, and pan-hypopituitarism. Now, it is very important to recall your prior knowledge on the determining factors of blood pressure, which are the cardiac output and total peripheral resistance. Blood pressure is a product of cardiac output and total peripheral resistance, whereas cardiac output is the product of stroke volume and heart rate. Next, you will need to remind of the neurohormonal mechanism in blood pressure regulations, specifically the baroreceptor effects, sympathetic nervous system, the role of catecholamines, the antidiuretic hormones, and the renal, renin, angiotensin, aldosterone system. So when the patients have an hypotension, you need to explore the history quickly. Usually the presenting symptoms could be a transient loss of consciousness, syncope, pre-syncope, giddiness, restlessness, chest pain, or breathlessness. We have to look for clue for causes, specifically fluid loss, such as diarrhea, vomiting, polyuria, bleeding, extensive skin damage or burn, reduced oral intake, such as nausea, frailty. Patients is so frail that they cannot reach out for fluid, and look for features of dysphagia. And go through their medications, specifically focus on antihypertensive and whether or not the patient is on long-term steroids. And you need to look for the features of autonomic dysregulations, specifically the history on diabetes mellitus with neuropathy, Parkinsonism, Guillain-Barré syndrome, trauma, and incontinence. You will next examine the patients with hypotension. Remember, if the patients have significant hypotension, you will need to examine while administrating concomitant resuscitations, measure the blood pressure in all four limbs, and check for hypotension defined as blood pressure less than 90/60 mm/Hg. If feasible, look for postural BP drop. That's mean systolic blood pressure drop more than 20 mm/Hg or diastolic blood pressure drop more than 10 mm/Hg after 3 minutes of change in posture. And you need to assess the patient's volume status and check for cardiovascular system and look for features of severe sepsis, and if there is, look for the source of infections. Now, the investigations of the patients with hypotension serve two main purposes. Number one is to look for complications. Number two is to look for cause. You need to take blood gas and lactate to look for metabolic acidosis and lactic acidosis. Do a bedside electrocardiogram and ultrasound and echocardiography. This is a POCUS to look for cardiac ischemia, look for internal organ bleeding, look for heart failure. Liver function test to look for ischemic hepatitis, although this may happen a few hours into the hypotension, and look for renal function tests as well to check for acute kidney injury. Next, you will do a full blood count coagulation profile to look for bleeding or disseminated intravascular coagulations. Check for CRP and blood culture if you are suspecting a septic shock as a cause of the hypotension. Random cortisol if you are thinking about Addison's crisis. But quickly, if you suspect Addison's crisis, take the blood and immediately administer the hydrocortisone. Do not wait for the result. Imaging of the spine if you are thinking about neurogenic shock, especially patients have incontinence and syndromes of cauda equina or conus medullaris. We will now look at three case reports. The case number one is hypovolemic shock, and this is published by Lucarin and colleague. The author described a 57-year-old woman presented with nausea, cramping, and urgency, passing black tarry stool. She denied abdominal pain, weight loss, or change in bowel habit. Significant past medical history are there are 2 previous admissions for Melina in 2005 and 2011, and the treating doctor has gave a provisional diagnosis of angial dysplasia. The first admission in 2005, they did a polypectomy and appendicectomy. In 2011, they found the scope was normal for upper and lower scope. In their family history, brother and mother have colorectal cancer. When we examined the patient, she was normotensive and which subsequently became hypotensive, presumably from a GI bleeding. Here are the investigations that have set up for these patients. Her hemoglobin was 12 and she has a normal esophageal gastroduodenoscopy. The team performed a CT angiogram after she became hypotension and found a large mass at distal bowel. From there, she underwent an urgent laparotomy and the large mass was discovered on the surface of the distal third of the small bowel. They have sent the sample for histopathology examinations and the final diagnosis is a GIST, gastrointestinal stromal tumor. So the specific management outline for these patients with a GI bleed from a GIST tumor are blood transfusions, surgical resection, and the subsequent oncology treatment, specifically imatinib. Now we look at case 2, postural hypotension. This is a case published by Lovegrove on Journal of American College of Cardiology case report on dysautonomia causing severe orthostatic hypotension, an important early finding in neurodegenerative disorders. The author described a 45-year-old man who presented with pre-syncope and dizziness but no syncopal attack, fall or injury. Since 2012, he had numerous autonomic symptoms such as orthostatic intolerance, erectile dysfunctions, thermodysregulatory symptoms, cold hands and feet, anhidrosis, early satiety, constipations, and poor urinary symptoms. On examinations, his lying blood pressure was 182/111, heart rate of 99 beats per minute. Immediately after standing, the blood pressure dropped to 137/88 and a heart rate of 130. 3 minutes of standing, the blood pressure was 122/79 and the heart rate was 114. This is a significant postural hypotension. The remainder of the cardiovascular findings, examination was normal. Here are the investigations that have performed on these patients on the 24-hour ambulatory blood pressure monitoring. The significant findings show the numerous episodes of spontaneous daytime hypotension to a nadir of 86/66 mm mercury. The author have performed a panel of metabolic and endocrine investigations and the causes was excluded. They proceed with autonomic nervous system studies and found that there's a postural BP drop of 40/30 without an increasing in heart rate. This is indicative of pan dysautonomia with a severe sympathetic and parasympathetic failure consistent with an underlying neurodegenerative process. The specific management outline for this gentleman with significant postural hypotension and features of severe autonomic dysregulations of a neurodegenerative cause is to obtain a neurology consult. He has later confirmed to have multiple system atrophy when he developed Parkinsonism, ataxia, and pyramidal weakness during the follow-up. The management would be multidisciplinary. Specifically for the postural hypotension, we can offer compression stocking. This is to increase the venous return and reduce the venous pooling at extremities. We can give a hydrocortisone, which is a mineralocorticoid for volume expansions. Now the last case study to showcase the approach to patients with hypotension with a problem of panhypopituitarism is a case published by Chang et al. They have described a 73-year-old man who presented with headache and chest pain after hit by a lorry. There's no significant past medical and family history. On examinations, patient's temperature was 37.6, tachycardia, tachypnea, and hypotension with a blood pressure of 82/55 mmHg. Of note, he has a pale face, wet and cold skin. Bilateral pupils are large and round, 2 mm in diameter, with a no response to light. They have performed a CT trauma protocol and found that he indeed sustained bleeding in the right basal ganglia area, right frontal parietal temporal subdural hematoma, and a subarachnoid hemorrhage. He also has left temporal occipital fracture involving the mastoid process. There's a small degree of pneumothorax in both lungs, and he has a traumatic red lung with bilateral pleural effusions. There's a bilateral partial rib, scapula, and sternum fracture. Given the initial hypotensions, the patient was treated for hypovolemic shock with a fluid resuscitations and inotropes. Nevertheless, despite 48 hours of adequate resuscitations, the patient remained hypotensive. A bedside echography showed insufficient volume and low cardiac output. A very observant doctors noted that there is a pale face, sparse eyebrow, and absence of armpit and pubic hair, led them to perform a pituitary hormone screen, which indeed show a pituitary hormone deficiency with low TSH, free T4 and T3, low FSH and testosterone, and inappropriate normal ACTH. And the MRI pituitary show a pituitary foci with irregular massive enhancement foci, which could mean bleeding into the pituitary adenoma. Now, the specific management outline for patients with hypotension secondary to traumatic panhypopituitarism is to administer timely hormonal replacement. We usually give hydrocortisone first, then levothyroxine. To prevent an Addison's crisis, we will consult a neurosurgery on the further management of the pituitary adenoma. Now, this is the end of the lecture on the approach to hypotensions, and we have covered the presenting symptoms, the examination findings, and key investigations and principle of management with regards to hypovolemic shock, postural hypotensions, and panpituitarism. You can write your questions and answer in the comment sections, and I'm happy to see you again in the next lecture. Bye bye.